Why don't we go ahead and get started? So today's Grand Rounds presentation will be from Alexis Beatty. And Alexis is right here in the front row. Alexis got her undergraduate degree in biomedical engineering at Duke and also attended medical school there. She did residency at Massachusetts General Hospital and then her cardiology training in both general and preventive cardiology at UCSF. After a year on faculty there, we were fortunate to have her join us here at the VA as an acting assistant professor. And recently she received a VA Career Development Award, and in association with that was selected for appointment as an assistant professor. And it's in association with that appointment that she is giving her presentation here today at Grand Rounds, so we can all get to know her a lot better. Her research interests are focused on mobile technology for home cardiac rehabilitation. She's been funded for that by her VA Career Development Award. She's also received funding from the Alpha Phi sorority, from the Locke Charitable Trust, and from the Seattle Institute for Biomedical and Clinical Research. Alexis has made other significant contributions to the literature regarding patterns of referral for cardiac rehabilitation after major adverse cardiovascular events, and on use of traditional versus novel risk factors to identify risk for secondary events or for major events in patients with stable coronary artery disease. She's been an invited speaker at the AHA Scientific Sessions. She's authored a chapter in the ACC ECHO SAP. She served on the Duke University Medical Center IRB fairly early in her career, and she is a member of the AHA Health Technology Scientific Advisory Group. She's also received awards, including the Elizabeth Barrett Connor Award in Epidemiology and Prevention for investigators in training, and here at UW, the Kaler Award for the Best Research Presentation at Faculty Research Conference in 2015. So today, Alexis is going to tell us about the future of cardiac rehabilitation.
Thank you for the opportunity to speak today, and I'm happy to get to talk to you today about the future of cardiac rehabilitation. And before I came up, Catherine actually asked me, she's like, well, shouldn't we be talking about the future of prehabilitation? And I think that, in 100 years, that's probably what we're going to be talking about, but for the time being, we still need to talk about cardiac rehabilitation. So today we're going to talk about the underuse of cardiac rehab. We're going to analyze some of the patient and health system barriers to attending cardiac rehab, and we're going to discuss some innovations in cardiac rehab delivery. And so because this is Grand Rounds and the grand tradition of Grand Rounds, I thought we would start with a patient presentation. So our patient is a 59-year-old male, and he has high blood pressure, high cholesterol, and is physically inactive. And he's been getting chest pains on and off for the past 2 weeks, mostly with exertion, but now they're starting to be sometimes at rest. And so he goes into his primary care doctor, who orders an EKG. He comes into the EKG department to get the EKG performed, and he has deep T-wave inversions and leads V1 through V3, and he's actually having chest pain as they're doing his EKG. So he gets seen by a cardiologist immediately and gets whisked away to the cath lab and has a stent placed in his LAD. Gets this whole new medication regimen prescribed to him. And then the morning after the procedure, as he's getting ready to be discharged, he asks us, well, what more can I do to improve my health? And so we tell him that he's lucky because there's this program, and it's called cardiac rehabilitation, and he can do cardiac rehab in addition to taking his medications and seeing his doctors to help him get better. And so cardiac rehab is a program of exercise training and health behavior counseling for patients with heart disease. And typical programs are 36 sessions, so 3 sessions per week over a period of 12 weeks. And these programs are multidisciplinary, so it's not just coming in to do exercise. So they're usually supervised by an MD, and then there is a nurse and an exercise physiologist, often a nutritionist, and a psychologist working with this program to provide multidisciplinary care for the patients enrolled in cardiac rehab. And it's more than just exercise training. So it's exercise training plus additional components to encourage behavior modification, to encourage behavior change, and then to really promote people developing self-management skills. And there are many indications for cardiac rehab. So after acute myocardial infarction, percutaneous coronary intervention, bypass surgery, chronic stable angina, valve repair or replacement, chronic stable heart failure, after transplant or VAD, and then very recently it's been approved as an indication in Medicare that gets reimbursed for peripheral arterial disease. And they don't call it cardiac rehab, they call it supervised exercise therapy, but it's basically the same thing. And so all of these are sort of the Medicare reimbursed indications for cardiac rehab that we have currently. And I think if I were to give this talk in maybe 5 or 10 years, we're probably going to add some more indications to this. I think there's emerging research on things like atrial fibrillation and diastolic heart failure. So cardiac rehab is known to improve outcomes. So there have been many clinical trials, many of them small, but when you look at this in meta-analysis, you see that cardiac rehab decreases hospital admissions. If you look at ischemic heart disease, it reduces hospital admissions by about 18%. And if you look at heart failure, it reduces readmissions by somewhere around 25%. It reduces cardiovascular mortality in patients with ischemic heart disease by also about 25%. And it improves quality of life in all populations studied. And when you look at cardiac rehab in relationship to some of the other interventions that we give that are widely accepted, like statins, we see that the magnitude of benefit is similar or roughly on par to these other therapies that we provide to people that are commonly accepted. And so because of all of this evidence, cardiac rehab is actually strongly supported in our guidelines. It's included in all of the guidelines for acute myocardial infarction and heart failure as a class 1 recommendation with level of evidence A. For chronic stable heart failure, it's a class 2A recommendation. And then it's also included in performance measures as a discharge performance measure for acute myocardial infarction. So it's one of the 9 or 10 things that the ACC-AHA recommends that you should check off the box that you do for every patient with an acute myocardial infarction before they leave the hospital. So you should refer everybody to cardiac rehab. And so all of this sounds great. So what's the problem? Why am I here? So when we look at whether people are actually getting referred to and attending cardiac rehab, we see that they're not. And so we recently looked at cardiac rehab referral in Washington State through the COPE registry. And so this is the registry of all cardiac procedures in Washington State at all hospitals in Washington State except the VA. And we see, so on the top is PCI and on the bottom is cardiac surgery. And each bar represents a hospital. And the y-axis is percent that were referred. And so for PCI, the average referral is 48%. And for cardiac surgery, the average referral is 91%. So cardiac surgery does a pretty good job in general of referring patients to cardiac rehab. But for PCI, we do a pretty bad job overall of referring people to cardiac rehab. And what's notable about this is that you see in this top group up here, there are some patients who are, or some hospitals who are referring most of their patients to cardiac rehab, but then we also have some hospitals down here who are referring very few of their patients to cardiac rehab. And so there's this huge variation in cardiac rehab referral. And if you look at this data nationally, we don't have quite the granularity as we do here, looking at a national level, but the overall rates after PCI are pretty similar. And if you look nationally after myocardial infarction, the overall rates are about 70 to 80%. So we're not referring all of our eligible patients to cardiac rehab. And then you take the next step, so referral, and then the next step in the chain is people actually going to cardiac rehab and participating. And when you look nationally at cardiac rehab participation, the national rate of participation is about 16% after MI, PCI, or CABG. And Washington State is about average at 15%. And this map shows in the dark blue is the top quartile of states participating And that top quartile is still only getting 24 to 42% of people participating in cardiac rehab. So even the states that are doing the best are still not really doing that great of a job of getting people to actually go to cardiac rehab. And some of these states that have poor participation, that are the lightest color states here, they have between 3 and 11% cardiac rehab participation. And so, there's clearly something wrong here. So we take this whole population of people that we have who are eligible for cardiac rehab, and then not everybody's getting referred. Even fewer are enrolling in cardiac rehab. And then if you want to take it even one step further, not even all of those who enroll actually complete cardiac rehab. So we have this huge gap in treatment of people who could be benefiting from this therapy who are not. And so I believe that there's tremendous opportunity for improving the use of cardiac rehab. And because cardiac rehab does have an impact on outcomes, I think that improving cardiac rehab will improve health for people with heart disease. And so going back to this patient that I brought up earlier, so he lives in rural northwestern Washington state. He works full-time, and it's just not feasible for him to go to cardiac rehab 3 times a week for 12 weeks. He'd have to drive an hour to get there. He'd have to take time off work, and he says, I can't do that. And so, what options do we have for this guy to attend cardiac rehab right now? And so, the barriers that he's encountering that keep him from attending cardiac rehab are common barriers. These are not things that are rare barriers. And when you look at the barriers to cardiac rehab, the point of this is not for you to read all of these. The point of this is just to show you that there are tons of factors that have been identified to be involved in people attending or not attending cardiac rehab. And there are many barriers to people coming in. And I think you can basically break down most of these into 2 big categories. One is health system barriers to attending cardiac rehab, and the other one is patient barriers to attending cardiac rehab. And we'll go through some examples of both of these. So with health system barriers to cardiac rehab, research has shown that some of the strongest predictors to cardiac rehab participation are distance to nearest cardiac rehab center. And then one of the other strong predictors is the strength of provider endorsement. And so what we do as providers matters to patients. And so we can have a big impact on whether people attend cardiac rehab or not. And then we also see many disparities with regard to participation in women and minorities. Women and minorities participate less in cardiac rehab. Women and minorities are also referred less to cardiac rehab. And so the problem starts early on with disparities in participation in cardiac rehab. And then if you think back to that map I showed you earlier, there's regional variation, right? And so some of this regional variation in cardiac rehab has been associated with things like socioeconomic status and cardiac rehab program density. But some of this regional variation is completely unrelated to these factors. Even after you adjust for socioeconomic status and cardiac rehab program density, there's still a huge amount of variation in cardiac rehab participation. And so there are other practice and hospital-based factors that are contributing to people not attending cardiac rehab. And I think a lot of this does actually boil down to dollars and cents. Historically, cardiac rehab was a money-losing venture for medical centers. And so it's hard to justify starting a program that's going to lose your hospital money. However, some of that has been changing over the last 5 years with increased reimbursement rates for cardiac rehab. And most programs are now finding that they're able to at least break even, and in some cases even make money for the hospital and health system. And so more than anything, I expect that that's going to have an impact on people actually having cardiac rehab centers and operating them. But dollars and cents do play a big role in this. And then, thinking about the other side here, barriers to cardiac rehab participation on the patient side. And these are only a few of them, but, it is just difficult to change people's behavior. This is not an easy thing to do. It does require an investment of time and effort on the patient's part and on the doctor's part or the other health provider's part. There's sometimes a lack of understanding. Some patients think, okay, well, I got my PCI, I'm all fixed, right? I don't need to do anything else. And some people have concerns about their general health status too, like, oh, aren't I too sick to go exercise? Like, that just seems like that's something I can't do. And a lot of patients do have safety concerns about whether or not it's safe for them to exercise. Many patients lack the family or peer support to engage in a program like this. People have to travel to the center, which is often difficult for people. And then there are financial barriers, both related to costs of travel and also costs of attending cardiac rehab. It usually does still require a copay to attend cardiac rehab. And for some patients, that's just too much. So there are a lot of patient-related barriers that we need to overcome too. And so the bottom line here is that there are barriers to cardiac rehab, and I think that because there are so many barriers, it's unlikely that any one strategy is going to be sufficient to improve participation, and so there needs to be sort of a concerted effort. So recently there's this program called Million Hearts, and so Million Hearts is a Department of Health and Human Services initiative to try to prevent 1 million cardiovascular events. And they're trying to do this through public health interventions. And so Million Hearts is a big program, but actually one of the things that they've selected as one of their projects is improving participation in cardiac rehab. And so Million Hearts has started this cardiac rehab collaborative, which I attend their calls. And it's got this group of stakeholders that's from people like American Heart Association, the program officers from the NHLBI, and a lot of community organizations to try to improve participation in cardiac rehab. And their goal is to go from where we currently are in 2017 of having very few people participate in cardiac rehab to, and this is a bold goal, to in 5 years having 70% participation in cardiac rehab. So they've kind of pegged this number as what we should be shooting for. And luckily, we do have some evidence-based ways to improve participation in cardiac rehab. So these are all things that have been shown, usually through multiple clinical trials, to improve participation rates in cardiac rehab. The first one is just automatic referral, so referring all eligible patients at the point of care, and so which can have a big impact on everybody getting referred and then increasing the percentage of people who get enrolled. The other thing that's probably the most effective thing, which is having structured nurse or therapist-led contacts. And so this is, a nurse or a therapist actually visiting the patient, usually in the hospital, and telling them what cardiac rehab is and encouraging them to go to cardiac rehab. And I'll just, we were looking at some data from UW, and we noticed that for years there were very few referrals to cardiac rehab from the cardiology service. There were a lot of referrals from the cardiothoracic surgery service, but very few referrals from the cardiology service. And then a couple of years ago, it got instituted that there was a default check mark for a PT referral on the order set. And after that happened, the referrals to cardiac rehab from the inpatient cardiology service skyrocketed. And so little things like this really do have a big impact on referral and enrollment in cardiac rehab. Other things that have been shown to be effective are early cardiac rehab appointments after discharge and tailoring of programs. And by tailoring, I mean having a women's session of cardiac rehab, or having a program that's tailored to a specific population that's underserved by cardiac rehab. And so looking at this, how do you go about improving cardiac rehab delivery? So I think there's really 3 big prongs to how you might do this, and probably all 3 need to be working together. So one is policy reform. There are some issues with how we reimburse cardiac rehab that need to be addressed. The second is cardiac rehab redesign to make it more accessible to patients. Clearly a big barrier is people going to a cardiac rehab center 3 times a week to attend cardiac rehab. So why don't we think of new ways to do this that don't require people to do that? And then the third prong, which is the part that I spend most of my time thinking about, which is technology facilitated cardiac rehab. So first, to talk about policy. So most policy in cardiac rehab is driven by Medicare, and that's partly because Medicare kind of leads the way for a lot of other insurance providers, and it's also partly because that's who is taking care of a lot of our patients who are attending cardiac rehab. And so there's a lot of initiatives from policy advocacy perspective to try to improve cardiac rehab participation. So one issue is that right now it's required that MDs supervise cardiac rehab programs. And so one big advocacy point is just to expand that requirement so that you could have supervision by NPs and PAs, so that you don't necessarily have to have an MD on site every single time a patient is participating in cardiac rehab. The other initiative that we're trying to get through is home cardiac rehab. So currently home cardiac rehab is not reimbursed by Medicare, and so therefore it basically doesn't exist in the United States. And home cardiac rehab is just as effective and safe as center-based cardiac rehab for most patients. And so those are two big initiatives to try to drive Medicare policy changes. And then we all got really excited earlier this year because Medicare announced these innovations projects. And there were two big innovations projects. One was this thing called bundles, which I won't go into very much. And the second one was a cardiac rehab incentive, which this region of the country was picked to be part of the cardiac rehab incentive. But it was announced a month or two ago that these were going to be canceled by the current administration. So the cardiac rehab incentive, though, was going to be paying the hospital where the patient is hospitalized for their MI or CABG for every cardiac rehab session that the person attends downstream. And it doesn't matter if they attend the cardiac rehab session at that hospital or at some other hospital. But they were really kind of driving it upstream to the hospital that's treating the patient for their MI or their CABG to try to get them to get the patient into cardiac rehab and get the patient attending. And they would get $25 per session for the first 11 sessions and $175 per session for the later sessions. And this is on top of the regular reimbursement for cardiac rehab. So hospitals could stand to make a substantial amount of money if they actually are able to improve their participation in cardiac rehab. But this innovation is currently on hold, but maybe it'll come later. And then there are pieces of cardiac rehab that are included or could be included in the recent Medicare payment reforms, also known as MACRA. And so MIPS, which is the Merit-Based Incentive Payment Program, actually includes outpatient cardiac rehab referral as one of its measures that you can track and get incentive payments based on, and so that's good. And then the advanced alternative payment models, the APMs, which are sort of focused on this concept of population health management, so managing the health of a population. I think there's also opportunities for cardiac rehab participation improvement within these APMs because cardiac rehab does reduce hospitalizations. It may be attractive for some health systems to try to promote more participation in cardiac rehab to drive down their hospitalizations and drive down the costs associated with that. And then a big area that people are looking into with improving cardiac rehab delivery is expanding the use of home and hybrid cardiac rehab programs. And so as you may guess from the fact that I'm just calling these home and hybrid, the structure of these programs I think varies widely. And some of the programs have people attend the first 12 sessions of cardiac rehab at cardiac rehab, and then they do programs at home or via telehealth. But some of these programs are really mostly home-based. So they usually have like one session with a provider at the hospital or clinic, and then after that the patient goes home, exercises at home, and usually has weekly check-ins over the telephone with their cardiac rehab providers. And these home programs have been shown to have similar benefits to center-based cardiac rehab programs, and they're sort of widely used and available in places other than the United States. And so this is a big part of cardiac rehab treatment in places like the UK and even in parts of Canada. And Kaiser does home cardiac rehab. So generally if Kaiser's doing something, it's often a pretty good idea. And we actually are doing home cardiac rehab programs at the VA too. So we have gotten funding to start a home cardiac rehab program at the Puget Sound VA, but that has not gotten off the ground yet. But it still suffers from the problem that these home cardiac rehab programs are not currently reimbursed by Medicare. And so therefore, we're just not using these in the United States right now. And so moving on to what we'll spend most of the rest of the talk talking about, which is improving cardiac rehab delivery through technology-facilitated cardiac rehab. And this is mostly using technology not as the only way to provide cardiac rehab, but using technology as a way to make it easier to provide cardiac rehab in non-traditional settings. And so this is using technology like internet, tablets, smartphones, sensors, so fitness trackers, wearables, and even relatively simple things like text messaging to try to improve participation in cardiac rehab. And so we all know that the use of all of these various pieces of technology is increasing rapidly. And Pew hasn't officially published their most recent numbers, but they've kind of given hints of this to show that they all keep going up the same way. And so cell phones, almost everybody has a cell phone, and most of the people who have cell phones have smartphones. And this continues to climb in older adults as well, so it's not just in the young ones. But we have a lot of challenges also with using technology. So if you look at the apps that are out there on the market that are health apps, only about 20% of health apps actually are based on theory or evidence. So most of them are just apps that were commercially created that aren't really rooted in medical care or behavior change. And then, not everybody is using apps for their health. About 58% of people, though, have downloaded a mobile health app. But then if you look at engagement, which is people actually continuing to use things over time, this study reported 46% of people were using apps over time, and I think that number is probably even too high, because most studies that look at app use over time are basically this graph that goes like this, where people start out using it a lot, and then they end up using it very little. And so when we ask the question, can we use mobile technology for cardiovascular health, I think we see that the enthusiasm for this right now is tremendous. But when you push the enthusiasm out of the way and you look at the evidence, you see that it still is very small. And so I'll go through a little bit of the evidence that we do have for using mobile technology for cardiovascular health. And probably the most common question that I get asked about this is, can't we just use a fitness tracker? Can't we just give everybody a fitness tracker? Isn't that enough? And the simple answer to that question of can we just use a fitness tracker is no. So the studies that have looked at basically just giving people a fitness tracker have shown that it's not effective to change behavior, and it's not effective to actually get people to be more physically active. And there have been multiple studies and even systematic reviews of this, that trackers alone are not enough. However, some of these studies have shown that when you have a tracker and it's paired with other intervention components, so other things that are like theory and evidence-based that we know work for behavior change and promoting self-management skills. So if you couple a fitness tracker with other intervention components, maybe like cardiac rehab, you find that a fitness tracker plus some other intervention components is actually effective at changing behavior. And this is a study of text messaging. So they enrolled 710 patients in Australia with coronary heart disease, and they randomized people to receive either usual care or a set of theory and evidence-based text messages. And they got 4 text messages a week for 6 months. And at the end of 6 months, they found that the group that got the text messages had significant improvements in their LDL, their blood pressure, their weight. And they saw these dramatic changes actually in physical activity and even smoking cessation. And so just getting 4 text messages a week in Australia or theory and evidence-based text messages resulted in significant improvements in cardiovascular disease risk factors. And then the study wasn't designed to specifically look at cardiac rehab, but they did notice that in the group that was randomized to the text messages, if they also happened to have attended cardiac rehab at some point during their enrollment or before their enrollment, they actually had 7 times the odds of being physically active compared to people who did not receive text messages and never went to cardiac rehab. And so there may be additive or maybe even synergistic effects with using interventions like text messaging coupled with other things like cardiac rehab. And so we actually just got IRB approved this week to start doing something similar to this study here at UW. So you may be hearing more about this to try to get text messages to our patients to encourage them to adopt healthy behaviors and attend cardiac rehab. Okay, and then this is another one of my favorite studies. So this study was also done in Australia, and this study looked at traditional cardiac rehab versus home cardiac rehab with a smartphone app. And they had 120 patients, and they found that the mobile group had significantly better participation, adherence, and completion compared to the traditional cardiac rehab group. And what was most important about this is that they showed that they were able to do this without attacks on the improvements that you see with cardiac rehab. So they were still able to get people to have similar improvements in exercise capacity, risk factors, and quality of life. And so they didn't dilute their effect. And so I think that this shows that smartphone home cardiac rehab can be effective compared to traditional approaches. And so we've done some thinking around how you should make and test a mobile app or mobile tools for cardiac rehab, and have come up with a set of things that we think are important. So one is that it should address the core components of cardiac rehab, so it should roughly resemble a real cardiac rehab program. We think it should be based on behavior change theory, because interventions that are based on behavior change theory are more successful. There's a significant amount of literature suggesting that there's a strong desire for individual tailoring, and that patients respond better to this in terms of engagement. So there should be some degree of individual tailoring. Sometimes that can be just like putting people's name in a text message. But sometimes it is actually, targeting things. Like that text message study I brought up before, they didn't send smoking cessation messages to non-smokers, and they didn't send messages about meat to people who are vegetarians. So, little things like that can matter so that you engage your population. Mobile technology needs to be usable. If it's not usable, people aren't going to use it, and they're not going to find it fun to use, so they won't keep using it. And we also believe that it should be shown to improve patient-centered outcomes, and efficacy needs to be demonstrated in a well-designed study. And then I've also come to believe that it's very important to study implementation in a clinical setting. So it's one thing to sort of give people an app or give people a program, and it's another thing to get them to adopt it in the context of their clinical care. And it's another thing to get providers to adopt it in the context of their clinical care, because providers will have to change their workflow and change how they're doing things. So we need to be thinking about this whole spectrum of things when we think about incorporating technology into what we're doing. And so I'll tell you a little bit about what I've been doing, which is working with the VA to create the VA's mobile app called VA Fit Heart. And I'm proud to announce that VA Fit Heart is now officially available for field testing. So we actually have veterans in the Puget Sound area who are using this app, which is kind of crazy. So VA Fit Heart is now in field testing. And so VA Fit Heart allows the veteran to set goals for physical activity, put in log information on their physical activity, blood pressure, heart rate, glucose, mood. It has little health education modules, and then it also lets them set up reminders and notifications to prompt them to make entries or engage in behaviors. And the neat thing about VA Fit Heart is that it communicates with this thing called the patient-generated database within the VA. And the patient-generated database will allow other VA apps to view the data that the patient is entering. And so the app that we've created to view the patient data is called CR Pro. And it lets the provider view patient goals, view the patient-generated fitness data and health data, and then to generate a report that gets sent to the electronic health record. And most commercial platforms that are doing things that are like care management platforms that are doing things similar to this, they do have, both patient-facing sides and provider-facing portals like we've developed here. And what's great about the VA one is that we're actually able to communicate directly with the electronic health record rather than creating like a PDF report or something like that. And so we've done some preliminary usability testing on our app, and the first version was not good. It had very poor task completion success rates, but based on the feedback that we got from veterans on what they had trouble using about the app, we were able to significantly improve the usability. And usually in the sort of user experience and usability world, they think that like a rating of 70 on the usability scale is acceptable. So we now have acceptable usability of our app. That's not to say that it's perfect. And so from interviewing veterans, we've found that there are a lot of factors aside from just the technology itself that will be important for use. And so based on a lot of these factors, we've kind of developed our intervention of how we're going to introduce this technology into the clinical setting. People are generally enthusiastic about it. People are interested in tracking their health measures, but people have identified that they really do want and think that they need introductory training for something like this. A lot of veterans who, average age is 63 in our sample, a lot of them wanted introductory training on how to use the app. They wanted someone to sit down or talk them through using the app the first time. And then people really expressed a strong desire to share their data with their providers. And this is actually in contrast to what you see with a lot of like commercial fitness trackers. So most commercial fitness trackers, when you ask people, do you want to share this data with your providers, most of them say no. But when you ask our patients who are potentially engaging in cardiac rehab, do you want to share your fitness data with your providers, most of them say yes. And so this is something that's interesting that I think will come up more in the future. But we still have many questions that remain about technology-facilitated cardiac rehab, and this is still a field that's in its infancy. So questions about design, questions about integration, informatics questions related to integration with EHRs, and then of course questions about implementation and, again, back to dollars and cents, reimbursement. So, in summary, cardiac rehab is underused, patient and health system barriers exist, but there are innovations coming down the pipeline that I think can significantly improve participation in cardiac rehab, and we will get to see all of these during the course of the rest of our careers. And so going back to our patient, so after his first heart attack, he did not attend cardiac rehab. He had a second heart attack. Luckily, between his first and his second heart attacks, he had moved to a city. So he's now able to attend cardiac rehab and participate in my study. So when I ask patients now what they can do, we strongly encourage them to go to cardiac rehab. I tell patients that I think it's worth the investment that they're making for their health to attend cardiac rehab. And yes, it's 12 weeks, but you need to make that investment to improve your health. And so what can you do as providers to help get your patients into cardiac rehab? So number one, you need to refer all eligible patients unless it's clearly contraindicated. You need to document. So where you can, please use electronic orders. That helps us to track this and monitor how well we're doing with this. And if you don't refer, please document why. And then the biggest thing that you can do is you can recommend it strongly to your patients. The strength of the provider endorsement in cardiac rehab is one of the strongest predictors of people actually attending. And so your recommendation really does matter to your patients. And so I hope we can go from this current model where we have not everybody getting referred, enrolled, and participating in cardiac rehab to a future model where we get more people getting this recommended therapy through technology or whatever other means we can. And I'd like to acknowledge all of the people who have helped me get here. And I'm happy to take questions for a few minutes. Catherine.
That's a great talk. I mean, I think it's a really important topic that we don't talk about much. I think, one thing is that the data is really most convincing for atherosclerotic disease of the coronary and periphery, yet things like valve disease are in there. And I think the data for, like sending somebody out for their transcatheter aortic valve or their circular aortic valve is less compelling. And it also, it isn't really tailored right now, so it leaves a lot of confusing questions. I mean, a young patient with a surgical valve who has Marfan, I get calls from rehab center, how much should they exercise? Well, they probably shouldn't be exercising that much at all. And they're being told about, atherosclerotic risk factors, and what they need to know about is anticoagulation and carditis prophylaxis. So it's not really tailored to those subgroups that are seen more and more. Usually, I think, interventional, I don't know what interventional is doing after transcatheter aortic valve, but how much a 94-year-old benefits from rehab, I think should be probably considered, whether that is beneficial. But I think the biggest problem with cardiac rehab is the names. I mean, rehabilitation has a really negative connotation, and you're obviously aware of that because of what you call, your app for the VA. And I mean, I understand it's probably have to be called rehab because that's what it's paid for, but maybe for our patients we could call it something like a heart health coach, or a personal training program, or something that they would want to do. I mean, rehab, you're telling your friends to go to rehab. Doesn't sound good.
Yeah, I mean, I think there's, there's a lot of things within that. So, you're right that the data especially for transcatheter valve is not there. People really haven't looked at cardiac rehab after transcatheter valves very much. But, in general, people who exercise and engage in self-management of their disease, there aren't too many studies of that show that it doesn't help people. So I think that right now it's probably something we can keep doing and keep monitoring the data. And you're right, we have a branding problem with cardiac rehab. It's not a great name, and we did very purposefully make ours more about health rather than disease, and so but I don't know, it's not really part of the movement that I hear about people talking about that, but people are talking a lot more about health coaching, and so that's kind of the exciting buzzwords that people are using both in the well community and then I think expanding to the people with disease. So if you look at programs like the diabetes prevention program, DPP, they very much use a health coach as part of their program. So it may be that we see that transition coming in cardiac rehab too.
Yeah, so I mean, the idea of referring people after an event, that's really straightforward. I see a lot of patients in clinic who had their infarction 10 years ago and moved to Seattle, or I picked them up from another provider and their event is really in the past. But they would clearly benefit from such.
Yes, so there's less data on people who are many years out from their event, but chronic stable angina is still one of the indications, and there are still some studies that include people with chronic stable angina. So you certainly can refer patients with chronic stable angina to cardiac rehab, and that gets reimbursed by insurance and Medicare. And then heart failure, so people with EF less than 35% are also eligible for cardiac rehab. And so anybody with, and it is chronic stable heart failure. So the way that it's written, you have to be out of the hospital for 6 weeks in order to start doing cardiac rehab. Yeah.
I actually got a couple of questions. I think there is definitely a digital divide. And I think the mobile apps are going to get much more used by younger, techno-savvy individuals. Number two, I'm interested in this success of the surgeons to get their patients to the program. And I think the obvious thing is that when you have heart surgery, that's a big event in your life. Angioplasty is becoming less and less of a sort of a life moment, if you will.
Yeah.
I mean, you're in and out the next day or the same day with your stent, and it doesn't have that psychological impact. And And I think I'd be interested to know how far patients are willing to come, for instance, for the cardiac rehab after surgery as compared to after an angioplasty.
Yeah, I don't know on your second question first in terms of how far people, this difference that we see between PCI and surgery for people attending. I don't know that anybody's done that particular study looking at, driving or travel distance differentials between PCI and cardiac surgery, but I think a big part of it is this, how sick do I really feel after this? Because after bypass surgery, people feel like, wow, I need rehab, But after PCI, it's like, I think Jamie said in his grand rounds a few months ago, he's like, it's like a dental cleaning now, like you just come in, you get it done, you leave, It's like not that big of a deal. And so, we have a little bit of that sort of perception of disease and health problem there that we need to overcome. But I think it still is beneficial for people after PCI, and so we need to be doing what we can to encourage people, because it is a chronic disease that you have. You have to take all your medications. You are at pretty high risk for having events, and things like cardiac rehab and learning self-management skills can certainly help with that. And then as to your first point about the digital divide, we certainly do have an issue with a digital divide with older adults not adopting technology as readily as younger adults. But I think some of that is changing, and I think some of that too, from what we're hearing from the people that we're interviewing about this, a lot of it is, it's not that they don't want to use it, it's that they don't know how. And so some of that I think can be overcome with training and other things like peer or family support. And so that's what we're focusing some of our work on, is understanding how you do that to get people to adopt the technology. But I think it's also true that like an app is not going to be right for everybody. And so we do need to be looking at multiple different modalities. And so an app is not going to be right for everybody. Some people will do much better with a center-based program. Some people will do much better with a home telephone-based program. Some people might do great with, text messaging, or, I had this company at this AHA Health Tech forum that I went to. They were showing this like AI robot that sits in your home and like engages with you. And so like there's, I think there's a lot of different, things that are coming up that, it's not one size fits all. So so we just need to find what works for our patient to get them to engage in this. Yeah, Jim.
I don't know if we've talked about this before, but I was wondering if you could sort of comment on the applicability or possibility of using cardiac rehab as a way to encourage advanced directed completion.
Yeah.
And ideally, you go to cardiac rehab, you sit there, you have a nice long discussion with whomever, going through all the issues, but maybe it's just a text message saying, have you done your advanced directive yet? Have you done your advanced directive yet? Have you done your advanced directive yet?
Yeah. And and no, you don't sound like a broken record, but but yes, certainly I think, other aspects of sort of like whole cardiac care and multidisciplinary care for patients can be part of cardiac rehab. So yes, smoking cessation, like you point out, is a big part. Okay, I think they're going to kick us out, right?
Yeah, they're going to kick us out. So thank you very much, Alexis, for really stimulating.